This is now the part 2 of case presentation format thyroid gland. So in the first part we discussed about the history taking and how to write it for the purpose of presentation in the university exam. That is my point of view. And this is the second part where we will be discussing about the examination and how to write that. So this again is from the student's perspective of how to write the findings that they get during examination in a format. So we stopped at history taking, so we continue from general examination. We move on to local examination. Then we go into the accessory examination, then other systems. That is for this session. So on general examination, we begin with slight modifications. Under a normal, if it was a medical patient being presented in the medical department, they would have more features added to this. So we'll see from the surgical aspect. So first of all, we'll be looking at the level of consciousness. So we have levels like unconscious, conscious, semi-conscious, stuporous. So for our purpose, since it is a patient being taken up for the examination, we'll have either the conscious or unconscious patient. So generally it is the conscious patient. So the person is conscious. The second point is orientation in time, place and person. So we usually inquire about what is the time, what did he have for breakfast. Then he will record and tell that he had so and so breakfast. Then he would know where he is, which hospital he is staying. Then who is with him, and who am I? Am I a doctor coming to see you? And who is with him? His son is there or daughter. So, but by that you will know that he is oriented in time, place and person. Second is the gait. So we can ask the person to stand up and take a few steps. And then normally we have normal gait. But again, from the physician's point of view, we have different types of gait that can be detected. That is like the Parkinsonian gait, high stepping gait, like that. For our purpose, we have only the normal gait. Next is the built and nourishment. So standard would be a moderately built person with moderate nourishment. But if the person is of short stature, then he would be of poorly built. And if he is usually above 6 foot, we can consider him as a well-built person. And similarly, poorly built, moderately built or well-built, all of them may be moderately nourished. Unless there is a disease which is causing a lot of loss of muscle mass and fat. So diseases like Thyrotoxicosis, cancer, cachexia, tuberculosis, these are known to make us poorly nourished. Similarly, obesity can be there in any of them, so they can be well nourished. So ideal statement would be to go ahead with a moderately built and moderately nourished person. And if you think otherwise, you can go for the appropriate terminology, like poor built or well built. But beware, once you do that, the person has to be in that category. So moderately built and moderately nourished includes a good set of individuals. Next is you begin to actually touch the person and examine further. So the initial things can be assessed by talking and seeing. So next is the pallor. So we look for the pallor in the eyes first. So in the eyes we look at the lower palpebral conjunctiva. So if it is less than pink or slightly towards the white pink or white color, it suggests that the person is pale. Similarly, in addition to the eye, you can also see the nails, the palms and soles, the general skin color, all may show pallor, that is a slight whitish shade of skin. All can be seen in actual pallor. So pallor generally is seen when you have anemia, but there are conditions like severe fright or anxiety, and you may be pale, but at the same time your hemoglobin may be normal. In hypovolemic shock, you may be pale, but the actual hemoglobin may be normal. So that is pallor. Second sign is icterus. So icterus is generally a sign seen in those who have jaundice or hyperbilirubinemia. But there are conditions where, supposing if you have beta-carotenemia, you may also have a slight icterus. So for the icterus, what we look at is the sclera. Since the sclera is white, so the sclera of the eye is generally white, so it is an easy way to contrast and to look for a yellowish tinge to it. Similarly, just like pallor, you can also look at the nail bed palms and soles, and general skin color for yellowish tinge. So classically it has been described that the normal bilirubin is 0.8 to 1.1, and hyperbilirubinemia would be above 1.1, but icterus would be detectable clinically only when the bilirubin is above 3 milligram per deciliter. Earlier it used to be 2 milligram per deciliter, but nowadays it is, for the last 10-15 years, it is 3 milligram per deciliter. So there may be a range of hyperbilirubinemia where icterus is not clinically detectable. Now moving on to the next one is cyanosis. So cyanosis means you have two types, that is peripheral and central cyanosis. So generally for cardiac diseases you may have a central type of cyanosis, and for general shock and other causes like that, you can have peripheral cyanosis. So in peripheral cyanosis, the bluish discoloration or purplish blue discoloration is seen in the fingers and toes. In central cyanosis, it is seen in the tip of the tongue, the central part of the lips, nose area, like that. So that's the two types of cyanosis, and generally it refers to the presence of deoxyhemoglobin in the blood. So at least 5 gram percentage of deoxyhemoglobin is required for it to be detectable. So that also means that if you have severe anemia with a hemoglobin less than 5, you may be relatively cyanosed, but clinically it may not be detectable since the proportion of deoxyhemoglobin may be less than 5 gram percent, though you are actually cyanosed. So there again is an exception. Next one is clubbing. So clubbing is like the bulbous enlargement of the distal phalanx or the fingers. So it has got two types. If when they ask you what's the types of clubbing, we generally refer to parrot beak type and drumstick type. If they ask you what's the grading of clubbing, then we have 4 grades. Grade 1 is the fluctuation of the nail bed or the nail fold. Fluctuation of the nail fold, that is the portion of skin just proximal to the nail. You will be able to shift it slightly from medial to lateral like that. So that is known as fluctuation of the nail fold. And the second thing is that when you place your 2 thumbs nail to nail, you will see a diamond shaped space there. That space gets obliterated because of a grade 2 clubbing. That's a Shamroth sign. So that's grade 2. And grade 3 means a parrot beak type of clubbing, and grade 4 means that you have the drumstick type of clubbing. So grade 4 is usually seen in hypertrophic pulmonary osteoarthropathy. So that's a relatively rare condition. So in that you can see a grade 4 clubbing. Now moving on. In generalized examination, we generally look for generalized lymphadenopathy. So you may see a single group of nodes sometimes enlarged, but depending on the local examination which you're going to do next, which depends on the history taking and what you see in general examination, based on that you will be thinking whether to further examine that single group of nodes. Otherwise, you are generally looking for a generalized lymphadenopathy. So here you would say that, what do you mean by generalized lymphadenopathy? If more than one non-contiguous groups are enlarged, that would suggest that it is generalized lymphadenopathy. So if you have the cervical group and the axillary group enlarged, considering that they are on the same side of the diaphragm, they are considered as contiguous groups. So that wouldn't be enough to call it as generalized lymphadenopathy. But if you had a group above the diaphragm and below the diaphragm, for example a cervical group and an inguinal group, or an axillary group and an inguinal group, that can be called as generalized lymphadenopathy. So based on that, so if you have generalized lymphadenopathy, you will say generalized lymphadenopathy is present. But on the other hand, only the axillary group is enlarged, then you can say there is no generalized lymphadenopathy, but the left axillary lymph node is enlarged. The details of that you will go under and after the local examination, where you will examine for the regional lymphadenopathy. For example, if it was a breast case and you're doing a left CA breast or a left breast lump, then the left axillary node would become important. Otherwise, we would be ignoring it in general. So, generalized lymphadenopathy. Now here I would like to mention that everything begins with a single group. So Even though we are clinically saying that there is no generalized lymphadenopathy, one of the most popular groups which is enlarged as part of generalized lymphadenopathy is the cervical group. So if you have the cervical group of nodes enlarged, we will say that there is no generalized lymphadenopathy, but the left cervical group is enlarged. You will image it later as part of evaluation. You will also do an ultrasound of the abdomen, and you may find out that the mesenteric nodes are also enlarged, and that would make it generalized lymphadenopathy later on. This is a clinical way of saying it. So when you clinically can't get any palpal nodes in any other group, you can just mention that there is no generalized lymphadenopathy and this so and so group is enlarged. Next is the pedal edema. So in dependent edema, you will get edema in the portion where the gravity is maximum, that is the foot and the ankle region. Similarly, if you're a bedridden patient, you can have it in the sacral area. So usually when you press with the thumb for 30 seconds, you can get a pitting type of edema. Next is the skin, hair and nails. So we can look at the skin for any dermatitis, fungal infections, ulcers. Similarly, the hair for alopecia, signs of protein energy malnutrition. In the nails, you can get mineral and vitamin deficiencies, lead poisoning. So you can say different features like koilonychia, fissuring, brittleness of the nail, white line, 50-50 nail. So many findings are seen in nails. So before going into the slightly additional features, level of consciousness, orientation, time, place and person, gait, moderately built and moderately nourished, pallor, icterus, sinuses, clubbing, generalized lymphadenopathy, pedal edema, skin, hair and nails. So you would comment that if they are all normal, you will say those things are absent, there is no, and then for skin, hair and nails are normal. Next, additionally, we will look for whether there is a thyroid swelling, whether any breast lump is there. Male or female, it has to be done. Similarly, there is no herniation from the anterior abdominal wall. There are no varicose veins seen and there are no ulcers seen. So this is the things that we add on to make sure that these are, since the common case presentations are a thyroid lump, breast lump, hernia, varicose vein and ulcer, we will be looking for it in general examination. And once you find it, according to that, you would move on to the local examination. So in this case, since we are discussing about thyroid, here a thyroid or neck swelling would be present. And then we will move on to the local examination of the neck swelling. Now, before going on, there is the vital signs. It's very essential that you must look for these 4 vital signs: the pulse, blood pressure, respiration, and the temperature. So in the pulse, there are many parameters, but what we commonly look is for the rate of the pulse, the rhythm, whether it is regular or irregular, the volume, whether it is normal volume or high volume or low volume like that, the condition of the vessel wall, whether it is thickened or not, and whether the peripheral pulses are equally felt on both sides. So the rate below 60 is bradycardia, above 100 is tachycardia, and the 60 to 100 is considered as normal. The rhythm is usually regular for sinus tachycardia. Now, if it is irregularly irregular, it would suggest a atrial fibrillation. The volume is generally normal and we look it for it in the common carotid artery, while the rate and rhythm are seen actually in the radial artery. Even the condition of vessel wall is assessed in the radial artery. So how do you know it? Well, the radial pulse is actually felt lateral to the flexor carpi radialis tendon in the wrist on the flexor aspect and against the distal styloid process of the radius bone. So when you usually palpate for the radial pulse, we get the cord-like tendon over there, and lateral to it we are feeling the pulse. We don't actually feel any structure, we just feel the pulse. Now imagine you feel a cord-like structure next to the tendon cord, and that cord which you are feeling is now pulsating like the radial artery. In that case, we would consider that as a thickened radial artery. Now this is the clue for atherosclerosis. So this thickening would be there throughout the body, and that would be hinting at a clause like atherosclerosis, especially in peripheral vascular disease. Now moving on to the peripheral pulses. So we have many peripheral pulses. You must individually look for all of them on both sides: the radial artery, ulnar artery, brachial artery. Then you move on to the axillary artery, common carotid artery, the facial artery, superficial temporal artery. You go down to femoral artery, popliteal artery, anterior tibial artery, posterior tibial artery, and dorsalis pedis artery on both sides. So next is the blood pressure. We will look for it in the using the cuff in the right upper arm in the sitting position. So and moving on to the next type is respiration. So the rate is usually somewhere between 12 and 16 per minute, and the type is depending on the sex. So if it is a female, it would be thoraco-abdominal type, and if it's a male, it would be abdominal thoracic type. If it's a child, irrespective of girl or boy, generally it is abdominal type. And a young child, like 1 year, 2 year, 3 year. And then next is the character. So in our case, it's a normal breathing, but in some we have the Biot's breathing, Cane-Stokes breathing. It's not relevant again in a normal patient. And the last vital sign is the temperature. You can use a thermometer, or you can use the extensor aspect of your fingers and feel for the temperature on the forehead. And that way you can know whether the person is febrile. So these are the 4 vital signs. So we're going to move on to local examination of the thyroid gland. So we have the methods of inspection and the methods of palpation. Now the method of percussion and auscultation are actually the same. So here, how do you inspect the thyroid gland? Obviously, you will stand in front of the patient and inspect the anterior aspect of the neck, or observe the anterior aspect of the neck. The second method is, in some cases, we can ask the person to extend the neck while clasping the fingers of both hands behind the back of the head and pressing against it. So that means there is the clasped fingers coming forwards and the head being pushed backwards. In such a case, you can look for the thyroid gland better, and that is known as the Pisler's method. So Pisler's method is a method of inspection, not a method of palpation. Now, if you are going to palpate the gland, what are the methods we have? So the standard method, we have methods known as Lahey's method and Kreil's method. Now I'm saying that, I'll tell you now itself, that is not the standard method of palpation of thyroid gland. The standard method is to examine the neck in flexion. That means you have to relax the neck on the side that you are examining, while you stand behind the person with both your thumbs touching the tip to tip on the occiput of your head or the back of your head, and the 4 fingers of both hands coming forwards. The palmar aspect of the 4 fingers are feeling the sides of the front of the neck. That way you can feel the right lobe, left lobe, and the isthmus, while you flex the neck in the direction where you are palpating. So if it's the right side you're palpating, you flex it slightly to the right and feel for the thyroid right lobe. And you're standing behind. That is the method of palpation of thyroid gland. Now in addition, so this particular method is obvious that you miss the posterior molar aspect of the gland. And individual nodules may require a little more specific examination, in the sense that whether a single nodule has malignant transformation or not, while the rest of the gland is normal. So what we can do is we have 2 additional methods. One is the Lahey's method. So the Lahey's method, you stand in front, and if you want to examine the left lobe, what we do is, using your left hand while you stand in the front, you push the right lobe of the patient medially. While you do that, what happens, the trachea and the thyroid gland together will have a slight circumferential turn anteriorly on the left side. At that point, the posteriormost aspect of the left lobe becomes amenable to, or becomes more easy to palpate with your right hand while you do this. So while you push the right lobe with your left hand, your right hand can actually examine the posterior aspect of the left lobe. Similarly, when you push the left lobe with your right hand, the right lobe will come slightly anterior and the posterior aspect can be palpated with your left hand. So Lahey's method is used for palpating the posterior aspect of the lateral lobes. Now the third method is the Kreil's method. This is for the individual nodule. You can palpate to see whether it is soft, firm or hard, and whether the surface is smooth. So individual nodule, you can place your thumb over it and feel the surface, and even ask the person to swallow so that the swelling moves and you can feel the entire individual nodule. So that is a Kreil's method. So now we are going on to the individual features. So we have inspection, palpation, percussion, auscultation. Now I'm not going to stress on the method examiner because that is for you to know, and that is the whole idea of MBBS and BDS courses. So now I will move on how to write. So the first 6 features that we generally look for on inspection, that is without touching. So we have the number of the swelling, the site of the swelling, the size of the swelling, shape, the position, and then you have the extent of the swelling. This much you can approximate and say while looking. Now a word of caution, we are present in the case after you complete the entire examination of thyroid gland. So at this point, when you present, you actually have completed everything and you know the exact size which is in palpation, the measurements and everything. So I would recommend that you say the same measurements as in palpation in order not to confuse the examiner. So the number is usually single. Sometimes it may appear to you like there are single or one or two prominent swellings on the left and right side. But mind you, if it is a multinodular goiter, it is the same swelling which has got 2 prominent nodules which is more seen. So it is best to take the number as a single swelling, because when you are presenting you would already know whether it is a thyroid swelling, the other one is a lymph node swelling. But if it is entirely a thyroid swelling with multiple prominent nodules, you go ahead with a single. The number of the swelling is single. The site is the neck. The size of the swelling is an approximate measurement, you can say. So you can go for, if it is depending on the shape, if it is a spherical shape, you can go for equal dimensions, 4 into 4, 5 into 5 centimeter. If it is ovoid, then one of the dimensions will be longer, so 4 into 6 centimeter or 6 into 3 centimeter, like that. Now if it is a butterfly shape, we can generally call it as irregular shaped. So that would be a horizontal dimension and a vertical dimension. And you can go for 12 into 6, 12 into 8, depending on what the actual measurement is, you can do it. And I would recommend that since this is an inspection and we can't actually measure with the measuring tape, we would use the word approximate next to the size to make it like as though it is a relevant, it's an inspection finding. So single swelling, site is the neck, size is 4 into 6, and shape is ovoid. And then the position. Now position is where in the neck is it? So it is the anterior aspect of the neck. That is the position. The next is so you can now say it as a sentence. A single ovoid shaped swelling of size 4 into 6 centimeter approximately is seen in the anterior aspect of the neck. So that's the way of wording it. We are not going to write number single like that. We will be saying it as a sentence. Now the next aspect of the position. So you know the site, the position. Now you must say in that position how far it extends, upwards and downwards and sideways. So for the horizontal extent, we have horizontally from the anterior border of the right sternomastoid to the anterior border of the left sternomastoid. This is the standard extent of a thyroid swelling. Now we have options like horizontally from the anterior border of the right sternomastoid to the posterior border of the left sternomastoid, if you think the swelling is larger on the left side. Similarly, you can take it from the posterior border of the right side to the anterior border of the left side, or posterior border to posterior border. So different combinations are there. The third option is horizontally from the anterior border of the right sternomastoid to the midline. This is if the swelling is definitely on one side only, like a right side, like a salty nodule thyroid, and you know on the other side you don't have a swelling. So you can select. The easiest and most preferred is anterior border to the anterior border. Little bit of laxity is given by the examiner when you present such things. But when you go for posterior border or midline, you must be sure that it is the posterior border and the limit is the midline. So when you move out of the anterior border to anterior border, you must be perfect in your findings. Now the vertical extent is usually from the level of the thyroid cartilage to just above the suprasternal notch, or you can say 1 centimeter above the suprasternal notch. Now here the level of the thyroid cartilage is relatively fixed, but the inferior limit, it may go beyond into the sternum, behind the sternum, that is retrosternal extension. So next option we have is vertically from the level of the thyroid cartilage to up to the suprasternal notch. So that means that the swelling is going behind the sternum. So we have this. So swelling extends horizontally from the anterior border of the right sternomastoid to the anterior border of the left sternomastoid, and vertically from the level of the thyroid cartilage to just above the suprasternal notch. So these are the inspection findings. Now moving on. Next you can see is the skin over the swelling. So what all can be there on the skin over a swelling? You could have a scar. So scar means that somebody did a thyroid surgery previously, some 15-20 years back, and this is a recurrence. Second is somebody did a lymph node biopsy, and this is a possibility that this could be some other pathology or a malignancy. So like that you can have a previous thyroid surgery scar or a previous lymph node biopsy scar. Second thing you can see is dilated veins. So dilated veins can be seen in large or huge goiter. A retrosternal goiter with superior vena cava compression can also have dilated veins in the neck. Similarly, you can have visible pulsations. And that may be seen in Graves' thyrotoxicosis, sometimes in other lesions like carotid body tumor or a carotid aneurysm. You can have thyroid malignancy having a visible pulsation. You can have pigmentations and ulcerations. This is also seen in a large or huge long-standing goiter with having pressure secondary changes on the skin. Even advanced thyroid malignancy, you can have ulcerations of the skin. Similarly, discoloration or erythema. This would mean alternate diagnosis like an infected thyroglossal cyst, infected sebaceous cyst, abscess, furuncle. So that can have erythema. Very rarely a thyroiditis may get complicated with the thyroid abscess. So that is also a way where you can get erythema. Now, next you can have is a discharging sinus. So this would mean a ruptured abscess or a ruptured or a thyroglossal fistula or a branchial fistula or a ruptured infected thyroglossal cyst, a tuberculous sinus. So a number of conditions are there where you have a discharging sinus or a hole through which or an opening through which pus is coming out. So the statement would be skin over the swelling is normal. There are no scars, dilated veins, visible pulsations, pigmentations, ulcerations, discoloration, erythema, or any discharging sinus. So that would make it as a no. If there is something, you can say that and say that. The rest of the things are no. Saying skin over the swelling is normal is not enough. You must mention that all these things are not there. When you do mention that, questions also may come as to what do you mean by dilated veins, or why you think that should come there. That's why I've explained that also. Now moving on to the next feature which can be seen on inspection, movement with deglutition. So a thyroid swelling usually moves with deglutition. In addition to that, you can have, in addition to a goiter, a thyroglossal cyst also moves with deglutition. A subhyoid bursal cyst also moves with deglutition. Now there are swellings that don't move with deglutition. That means the general other swellings like dermoid cyst, lipoma, sebaceous cyst. So there are a number of midline conditions, midline swellings, of which these three move with deglutition: goiter, thyroglossal cyst, and subhyoid bursal cyst. So by doing this single test, you can make sure that all others are not there, and this is the one that we are suspecting. Now moving further, you have the movement with protrusion of tongue. Now swellings that move with protrusion of tongue is actually the thyroglossal cyst, because it has got an attachment to the foramen cecum in the tongue through the thyroglossal tract. That's why it moves with protrusion of tongue. While goiter and subhyoid bursal cyst do not move with protrusion of tongue. Now subhyoid bursal cyst the location is obvious. It is just beneath the hyoid bone, which is way above the thyroid cartilage. While the goiter would be below the thyroid cartilage. Now there are rare conditions where, like papillary carcinoma thyroid and all, where sometimes a portion of thyroid gland, the malignant deposit, may be in the subhyoidal region. I've come across such a case recently, and so it was initially suspected to be a thyroglossal cyst, but it was not midline, it was slightly left paramedian, but it was next to the hyoid bone, and we found out that there was a tract of tissue connecting the swelling to the pyramid lobe, which was attached to the left lobe. So such things also can happen. So there is no hard and fast, there is always exceptions to everything. Now moving on, you have the position of trachea. Trachea usually appears to be central, but it can be pushed to the left or to the right, depending on if it is a one-sided swelling. If you have a right-sided thyroid swelling, the trachea can be pushed to the left. If it's a left-sided swelling, it can be pushed to the right. Now the last sign, again a sign that may put the patient in distress, so we would be doing it at the end of examination, but we will be quoting it under inspection. Pemberton's sign. So it's a sign. If it's negative, it means that there is no retrosternal extension. If it is positive, that means when you elevate your upper limbs in such a way that the arms touch your ears and you wait for up to 6 to 8 minutes, the thoracic inlet space becomes narrow, and if at all there was a retrosternal goiter or a retrosternal extension, at that point, if it is narrow enough, it may press on the superior vena cava and result in superior vena cava obstruction. And that will result in facial puffiness, periorbital puffiness, and dilated veins and facial flushing. So that would mean that the Pemberton sign suggests a superior venical compression. Now, if the patient obviously had superior venical compression, then these dilated veins would be seen at the time of presentation itself. You would not have to do a Pemberton sign. This is a case which is likely to develop superior vena cava obstruction because there is a good amount of retrosternal thyroid tissue. So now we are moving to a second phase, that is palpation. So the first two things you always look for is the localized rise in temperature and the tenderness, because once you start touching, the person may have pain and the skin will appear warm at the end of your examination because of repeated examination. So we look at the beginning itself. So you look it for using the dorsum of your fingers, and you can look for the localized rise in temperature. So if it is present, it means some infective or inflammatory pathology. So we can have the infected sebaceous cyst, infected thyroglossal cyst, abscess, furuncle, subhyoid bursitis, even sometimes, then you have the Graves thyrotoxicosis, where the actual goiter is warm. Now it can be absent in a regular multinodular goiter, a thyroid neoplasm, a simple lipoma, dermoid cyst, sebaceous cyst, thyroglossal cyst, that is without any infection. The second sign was tenderness. So tenderness may be present in thyroiditis. If there is hemorrhage into a nodule in the multinodular goiter, then the earlier mentioned conditions, that is infected sebaceous cyst, infected thyroglossal cyst, abscess, furuncle, subhyoid bursitis. Now it is usually absent in a multinodular goiter, thyroid neoplasm, thyroglossal cyst, lipoma, dermoid cyst, sebaceous cyst. So in exceptional cases, you can have. So one of the nodules may be thyroiditis, one of the nodules may be hemorrhagic, so you can have tenderness. So that is the various things that can cause tenderness in the neck swelling. Now here I have not mentioned about lymphadenitis, so there are many more causes for tenderness in the neck. You can have lymphadenitis, Ludwig's angina, so like that. So there are many more pathologies there. So how would you word it? Next, after saying that there is no localized rise in temperature or tenderness, you can move on to say the next thing. The first 6 findings we saw in inspection. So inspection findings are confirmed. Now you will be measuring, feeling, examining, touching, and you know the limit. So a single ovoid shaped swelling of size 4 into 6 cm is palpated in the anterior aspect of the neck, extending horizontally from the anterior border of right sternomastoid to the anterior border of left sternomastoid, and vertically from the level of thyroid cartilage to just above the suprasternal notch. So that is the statement without the words approximately, and seen is replaced by palpated. So now we know that these are the findings that you have examined. So once you touch, next thing is to find out what is the consistency of the swelling. You can have soft, firm, or hard. Soft can be seen in colloid goiter, colloid nodule, thyroid neoplasm. Firm can be seen in thyroid neoplasm, thyroiditis, MNG. Hard can be seen in Riedl's thyroiditis, thyroid carcinoma. So generally we would go for a firm or a soft consistency depending on how it is. Surface. The surface is usually smooth. Example, colloid goiter, Graves' disease. A single nodule in MNG may be a smooth surface. A salty nodule thyroid. A surface can be nodular in a multinodular goiter. So here you have two options. I told you in the beginning that sometimes you may see two obvious swellings on the side, and they are one and the same because they all move with deglutition. So for the ease of presentation, after you examine, you will know that it is the same swelling. So you can go for surface is nodular. But when you see that two prominent nodules, you can mention it. The surface is nodular with two prominent nodules of size 2 into 2 cm and 3 into 2 cm on either side. Or you can specifically say of one nodule of size 1 into 2 cm in the right lobe and 3 into 2 cm on the left lobe. So you can mention that in that way, saying that there are two prominent nodules in that surface. The next thing is to say that the surface is irregular. That suggests a thyroid carcinoma. Now regarding the borders. So Usually all borders are well defined, including the lower border. Now I told you the case where it may go in for retrosternal extension. Then you will be saying all borders are well defined except the lower border. When you say that, you must add an additional point on palpation of lower border. So here you have two options. Mild retrosternal extension means that when you actually swallow, when the gland goes up, you get the lower border. Significant means that even though you swallow and it goes up, still the lower border is not palpable. So we have two options. If you say all borders are well defined except the lower border, the next thing would be to go to lower border is palpable only on deglutition. Or you can say lower border is not palpable even on deglutition. Now you have got the surface, the consistency, surface and the borders and the lower border. We're moving on to mobility and plane of the swelling and the special mobility. So mobility means the swelling actually has no independent horizontal mobility, but it moves along with the trachea. So a thyroid swelling has no independent mobility, but it moves along with the trachea. Then regarding the vertical mobility, we know it moves with deglutition, but in reality it is not freely mobile vertically. So we can go for swelling has restricted vertical mobility. Now some may prefer to say the swelling has no vertical mobility. It is basically like shaking the hands without actually moving your elbow. So the back of the thyroid gland doesn't move when you move it up and down. So that's depending on your institute, you can go for it. I would recommend to go for swelling has restricted vertical mobility, since we can move our hands up and down, but it is not freely mobile. Now the third option, that is the option which is rarely seen, that is in advanced malignancy. So the swelling is fixed. It can be seen in advanced anaplastic carcinoma, Riedel's thyroiditis. Now regarding the planar swelling, so we know that because it moves with deglutition, the plane is within the pretracheal fascia. But clinically when you assess it, you have to say it is deep to skin by simply pinching the skin. Then you have to say it is deep to the platysma, which is a subcutaneous muscle in the neck. And that you can see by clenching the teeth, and you can see the swelling becomes less prominent. But this is not obviously seen because that it's a very fine sign. But we know this is if it moves with deglutition, you can go ahead with saying that it is deep to platysma. Now the next way is to say deep to investing layer or deep fascia. This we check by actually extending the neck on that side. So if you want to check the fascia on the right side, if it's a right side swelling, we turn the neck to the left side. If it's on the left side, you turn to the right side. If it's in the anterior aspect, we extend the neck. In all these cases, the fascia gets stretched and the swelling becomes less prominent. This is different from the Pisillow's method, where I said that it becomes better seen. And the reason is there you have a clasp hand and there is a counter with that clasp hand against the extension of the neck. That is different. This is different. This is mean only the extension is there and that stretches the fascia, and if anything is deep to the fascia, it becomes less prominent. Now next is deep to sternocleidomastoid muscle. Though it is within the investing layer, we can turn the neck to the opposite side. That would mean the fascia is tense and against the resistance of our hand, that is the examiner's hand. So as the examiner is pushing to the same side and the person is turning to the opposite side. Like that, the sternocleidomastoid becomes tense or contracts, and then the swelling becomes less prominent. So these are the ways of saying the swelling is deep to skin, deep to platysma, deep to investing layer, or deep to deep fascia, and deep to sternocleidomastoid muscle. So that is the plane of the swelling. The next thing is the two special mobility. So we have movement with deglutition. So you hold the swelling and ask the person to drink a glass of water. The swelling moves with deglutition, or it doesn't move with deglutition. I've already explained this. Next is you feel the gland again and ask the person to open the mouth and protrude the tongue. You may feel a slight tugging sensation if it moves on protrusion, and that means a thyroglossal cyst. But a general goiter will not move on protrusion of tongue. Now the next is position of the vital structures like the trachea. So trachea is central. You can palpate it using your middle three fingers. Middle finger on the thyroid cartilage, and you trace it down along the tracheal rings, while you keep your second, that is the index and ring finger, on the two clavicular ends attaching to the sternum, and you trace it whether the trachea is pushed to the left side or to the right side. And next is the position of the common carotid artery pulse. Usually normally felt on both sides. That means medial to the sternocleidomastoid muscle and lateral to the thyroid cartilage. That's the area where you usually feel it. Now, if there is a swelling there, and then, for example, if it's a left-sided thyroid swelling, the common carotid pulse may be pushed much laterally on the left side. So instead of getting it there, you may get it more posterolateral. Similarly, if it is not felt on that side, that does not mean that the pulse is absent. It may be the Berry sign, which again I'll discuss it after some time. So sometimes what happens, the thyroid malignancy may encase the common carotid on that side in such a way that you are unable to elicit a pulse. The artery may be still patent, but you are unable to elicit the pulse. So that is the Berry sign. So if the Berry sign is negative, you can say that. If it is positive, that means that the pulse on that side is not palpable. Again, it's a feature of advanced thyroid malignancy. Now the Cocker's test is a test, again, just like Pemberton, that may cause the person to go into distress. So you need to press the lateral lobes, both lateral lobes of thyroid from either side. And if there is tracheal narrowing, the person will develop stridor. So again, for mild to moderate swellings, you can just go ahead and do. But for large swelling, it would be better that you just record it and say that it was not done, or you did mildly only and you got a negative. You didn't do it significantly or properly because we didn't want the patient to go into stress. Now the next aspect or the third element is percussion. So in thyroid gland, we don't percuss over the gland because anyway the trachea is there and you may get impaired resonance irrespective of the size. So we percuss over the manubrium sterni to look for a resonant note. If it is resonant, that means there is no thyroid tissue or no tissue that is causing, that is like, for example, there is no retrosternal extension or any retrosternal mass like a thymoma or anything. So if it is a dull note, that means that the thyroid gland has got a retrosternal element or there is a retrosternal mass. Normally, the manubrium sterni is always resonant. Now the fourth and last element is auscultation. So again in thyroid we don't auscultate much for any air entry and all because of the trachea is there, but basically we auscultate for a bruit in the thyroid, in the superior aspect of the lateral lobes. That's the location where the superior thyroid artery comes. So in a Graves' disease or primary thyrotoxicosis, and sometimes in a thyroid carcinoma, you may hear a thyroid bruit. Normally it is not heard. It's a machinery type murmur which you hear it while auscultating over the location of the superior thyroid artery. Now once you finish local examination, we still have the element of hyperthyroidism. So we had to look for the signs of toxicity. Tachycardia. So in thyroid, there is a characteristic type of tachycardia known as sleeping tachycardia. So during sleep, normally if you are toxic, if your heart rate goes above 90 and is between 90 to 100, it's called grade 1. So this is different from the regular tachycardia where the tachycardia is above 100 is considered as a heart rate above 100 is considered as tachycardia. In sleeping tachycardia, a heart rate above 90 is considered as grade 1, above 100 is considered as grade 2, and above 110 is grade 3. It's a Kryl's grading. So you can have initially sinus tachycardia where your rhythm will be regular, or you can have a set of supraventricular tachycardias where you have irregular rhythms. So you can have paroxysmal atrial fibrillation, persistent atrial fibrillation, paroxysmal atrial tachycardia, persistent atrial tachycardia, multiple ectopics. So these are the various things that can be seen. Now next is tremor. So you can have tremors of the hand. You have to outstretch your hand with the fanned out fingers and you can see the fine tremors of the fingers. Similarly, on looking at the tongue while opening the mouth, you can see the tremors. Then the skin or the palms and the skin in general would be warm and moist. There would be palmar sweating. Then you have a set of eye signs which are seen in thyrotoxicosis. Again, in secondary thyrotoxicosis, you don't see much, but in primary thyrotoxicosis, you can come across eye signs. So we have the Von Graves sign. So here what you do is you keep the patient sitting in front of you. You fix the head by placing your left palm over the head. And then you ask the person to look upwards and downwards. So while the person, that is the head does not move, only the eyes look up and down to a certain degree. So you know that normally when you see at the eye, the upper sclera is never visible. The upper sclera and a part of the cornea, 1 to 2 mm, is covered under the upper lid. So what we are looking here for is a lid lag. That is, when the person looks up and then down, if the upper lid lags behind the eyeball, then suddenly you will see that earlier you were not seeing the upper sclera, but now while looking downwards, the upper sclera becomes visible. So this means that the Van Graaf sign is positive. The second is the staring look and with infrequent blinking. So normal person blinks around, let's say 15 to 20 times in a minute and maybe even more. But in this case, you may only blink once or twice in a minute. And the person has a staring look of bulging eyes. That is known as the Stellwag sign. For this, you just have to look at the person and observe for a minute. Next is a Geoffroy sign. So the earlier mentioned same position, you're sitting in front, you're fixing the head with your palm so that the person doesn't turn the head upwards while looking. And here what you're looking for is, while the head is kept slightly downwards or even slightly straight or with partial downward gaze, you ask the person to look upwards. So when we look up, it is natural for us to use our forehead muscles and there will be wrinkling in order to look upwards. Now if you have exophthalmos, the eye will be able to look upwards even before you use the forehead muscles. So you will not require to use the forehead muscles and so there will be no wrinkling. So absence of wrinkling would suggest a positive Geoffroy sign. That is, while keeping a downward gaze, while the head is fixed, the person is asked to look up and the person will be able to look up without any wrinkling of the forehead. Now the next is the Dalrymple sign. This means the straightforward thing, the upper sclera is already visible even without any movements. So the upper sclera is already seen. That again suggests a exophthalmos. The Mobius sign and the Nafziger test. So Mobius sign is slightly different from the other sign in the sense that it is a feature of ophthalmoplegia due to the thyrotoxicosis. So here what happens is that the eye is unable to converge. So when you sit in front and you ask the patient to look at your index finger and you are bringing the index finger from the distant point to a nearby point in front of the eyes in the midline slightly below. So when you bring from a distant to a near point, the eye usually converges to that point in the middle. So you can see both eyes converging to that point. So here there will be failure of convergence. So it's basically a regular eye test where you look at the convergence accommodation reflex. The next is the Nafziger test. The examiner stands behind the patient and observes the protrusion of the eyeballs while keeping the neck extended, and you are observing through the supraciliary arch or the supraorbital margin. You are looking tangentially to the cheeks from the back of the patient while the neck is extended. So we are observing through the forehead, through the supraorbital ridge, and looking to see whether the eyeball is protruding beyond the orbital margin. So that is a sign, again a test for exophthalmos, so Nafziger test. Now you can also do a test using the exophthalmometer. So Nafziger test is the clinical way of looking for exophthalmos. So there are a number of maybe even 15-20 named signs. So these are the 6 important signs that we need to mention. Now in addition to the other toxic features include proximal myopathy. The person may have difficulty in combing hair or raising his arms above the shoulder, in sitting from a standing position or standing from a sitting position. All suggest proximal myopathy affecting the hips and shoulders. Then in certain cases you can see pretibial myxedema. Now this is a feature, though a feature of toxicity, it's usually seen several years after an undetected toxicity. So the moment when you see the toxicity may be mild. So there is mucin deposition on the front of the shin or the legs, and there will be some sort of edema in that area, or it is a thickening of skin in the shin. So it's not a feature seen during the toxicity. It may be seen a few years after the toxicity. Now sometimes unexplained vitiligo may be due to toxicity. So these are the signs of toxicity. So we have tachycardia, tremor, warm moist skin, eye signs, proximal myopathy, pretable myxedema, and vitiligo. Now once you finish the local examination and the signs of toxicity, we move on to examination of the regional lymph nodes. So again, the regional lymph nodes here would be the neck lymph nodes or cervical lymph nodes. So level 1 to 6 from both sides will be examined while standing behind the patient, just like in thyroid, and using the palmar aspect of your medial four fingers. And whichever side you examine, you flex the neck on that side. You feel for the level 1A, 1B, 2, 3, 4, 5, and then the level 6. Level 6 would mean in the same area as the thyroid gland. Now in thyroid carcinoma, you can get enlarged nodes in the, so you can have medullary carcinoma, anaplastic carcinoma, and our more common papillary carcinoma may have a lymph node enlargement. Now sometimes even autoimmune thyroiditis can have a enlarged lymph node, as well as lymphoma and other causes can have enlarged lymph nodes. Now the next element and the last element is the systems examination. So we will go through the 4 systems. You have the cardiovascular system. So you need to make a brief note in such a way that inspection, palpation, percussion, auscultation of that system is briefly done. So this is my take on it. You can see the apical impulse of the heart medial to the midclavicular line in the left fifth intercostal space. Not only see, you can also palpate it. So that is the cardiac impulse. Then you can auscultate for the first and second heart sounds, and you can look for any murmurs. The respiratory system, you can look for the chest wall movement on both sides and comment that it's equal. Then you can percuss on both sides of the chest, that is all 9 areas, and you can say that the resonance is normal. Then you can auscultate and hear for the normal vesicular breath sounds, and again you can rule out added sounds. For the CNS, you can assess the higher functions by looking at the speech and memory, and you can look for the focal neurological deficit, whether there is any weakness of any part of the limb. You can examine the skull and spine. Now in the spine, if it is a metastasis from a malignancy, you can have a tender area, while if it is a skull region, a metastasis or a bony pulsatile metastasis to the scalp can occur in follicular carcinoma thyroid. It's a rare feature, but it is seen in follicular carcinoma thyroid. So you can look for any obvious swelling in the skull area or scalp region. Now the next is the GIT. You can examine the oral cavity, whether any lesions are there in the oral cavity, which may be a cause for head and neck lymphadenopathy. So oral cavity can be assessed. Then you can examine the abdomen, look for tenderness anywhere, or any hepatosplenomegaly. Again, can be seen as part of lymphoma. And sometimes hepatomegaly can be seen as part of metastatic spread from follicular carcinoma thyroid or papillary carcinoma thyroid. Then you can percuss all areas of the abdomen for normal resonance, and bowel sounds can be heard. So that would suggest a normal GIT examination. So now the final thing, I will be going through the case format, which is a sample of same as what was discussed in the history taking. Name is Shobana. She's 50 years old. She's a female. She's housewife, and she lives in Calicut. Her chief complaint is a swelling in the front of the neck of 10 years duration. History of present illness. Patient was apparently normal 10 years ago. She instantly noted a swelling in the front of the neck 10 years ago. The swelling was initially small and gradually increased in size over the last 10 years to attain its present size. There is no history of any recent rapid increase in size. The swelling is not associated with any pain or discoloration or pus discharge from the overlying skin. There is no history of any difficulty in breathing or any difficulty in swallowing or any hoarseness. There is no history of any recent change in weight or appetite. There is no history of any anxiety, restlessness, tremors, heat intolerance, preference to cold, palmar sweating, menstrual irregularities, insomnia, bulging out of prominent eyes, or double vision, or any palpitation. There is no history of any cold intolerance, preference to heat, dry skin, tiredness, lethargy, daytime sleepiness, poor memory, menstrual irregularities, or infertility or constipation. There is no history of any chest pain, exertion, or any exertional dyspnea or any breathlessness or exertion. There is no history of any other neck swelling or any scalp swelling. There is no history of any cough, hemoptysis or breathlessness. There is no history of low backache or any yellowish discoloration of skin or sclera. Regarding the past history, there is no history of any similar illness in the past. There is no history of any previous neck surgery or any irritation to neck. There is no history of any hypertension, diabetes, mellitus, asthma, COPD or any ischemic heart disease. Regarding personal history, her sleep is normal, appetite is normal, the diet is non-vegetarian, bladder habits are normal, bowel habits are normal, there are no addictions. Her menarche was at the age of 13 years. Periods are regular 5 to 6 days every 28 to 30 days. Now here you can mention accordingly. If she's 50 years, you can forget about the periods and directly go for menopause at the age of 50 years. Marital history, she's married with 2 children. Now family history, there is no history of any similar illness in the family. There is no history of thyroid disease or thyroid malignancy. There is no history of any comorbidities in the family. Socioeconomic history, she belongs to a middle class family. Treatment history, there is no history of any treatment for hypothyroidism, hyperthyroidism, hypertension, diabetes mellitus or coronary artery disease. General examination, she is conscious and oriented in time, place and person. Gait is normal. She is moderately built and moderately nourished. There is no pallor, icterus, sinuses, clubbing or generalized lymphadenopathy or pedal edema. Skin, hair and nails are normal. There is a neck swelling. There are no breast lumps, varicose vein, hernia or ulcers. Vitals, pulse rate is 72 per minute, rhythm is regular, volume is normal, condition of vessel wall is not thickened, peripheral walls are felt equally on both sides. Blood pressure is 120/80 mm mercury in right upper limb in sitting position. Respiratory rate is 14 per minute, thoracoabdominal type and character is regular. Temperature is normal, she is afebrile. On local examination, on inspection, a single irregular shaped swelling of size 12 into 6 cm approximately is seen in the anterior aspect of the neck, extending horizontally from the anterior border of right sternomastoid to the anterior border of left sternomastoid and vertically from the level of thyroid cartilage to just above the suprasternal notch. Skin over the swelling is normal. There are no scars, dilated veins, visual pulsations, pigmentations, ulcerations, discolorations, erythema or any discharging sinus. The swelling moves with deglutition and does not move with protrusion of tongue. The position of trachea appears to be central. Pemberton sign is negative. On palpation, there is no localized rise in temperature or tenderness. Inspection findings are confirmed. A single irregular shaped swelling of size 12 into 6 cm is palpated in the anterior aspect of the neck, extending horizontally from the anterior border of right sternomastoid to the anterior border of left sternomastoid and vertically from the level of thyroid cartilage to just above suprasternal notch. Swelling is firm in consistency. Surface is nodular with 2 prominent nodules of size 2 into 2 cm and 2 into 3 cm on either side. All borders are well defined, including lower border. The swelling has no independent horizontal mobility but moves along with trachea. It has restricted vertical mobility. It lies deep to skin, deep to platysma, deep to deep fascia, and deep to sternocleidomastoid muscle. It moves with deglutition, does not move with protrusion of tongue. Trachea is central in position. Common carotid pulse is normally felt on both sides. Berry sign is negative, Cock's test is negative. Percussion as resonant note is percussed on the manubrium sterni. On auscultation, no thyroid bruit is heard. Signs of toxicity, there is no tachycardia, no tremors of hands or tongue, no warm moist skin or palmar sweating. Eye signs are absent. Von Graffi sign absent, Stellwag sign absent, Geoffroy sign absent, Mobius sign absent, Dalton sign absent, Nafziger test absent. No pretable mixed edema, no proximal myopathy. Examination of regional lymph nodes, no enlarged cervical nodes. Examination of other systems, CVS, epicalymphicals is seen and felt medial to the midclavicular line in the left fifth intercostal space. First and second heart sounds are heard, no murmurs heard. CNS, higher functions normal, no focal neurological deficit. Skull and spine normal. Respiratory system, chest wall is moving equally on both sides. Normal resonance is noted on percussion in all chest areas. Normal vesicular breath sounds are heard in all chest areas, no added sounds. GIT, oral cavity is normal. Abdomen non